is not the update that I wanted to give. I was supposed to graduate from my IVF clinic today, but during that final ultrasound, there was no heartbeat.
So I've been following Kellie Girardi's IVF journey to overcome secondary infertility for a long time, and I'm sure a lot of you have been as well. And when I found out this weekend that she miscarried after transferring her one euploid embryo, it truly felt like a gut punch. This does not happen often, but when it does, it is truly devastating. And I still remember every single time, every single patient that this has happened to of mine. It's something that leaves me and the patient both blindsided in that moment. Nothing can prepare you. A lot of you have DM'd me about how understandably anxious this story has made you feel, so I wanted to make a video about PGT normal embryos, euploid embryos, those with the correct number of chromosomes, how they can still sometimes result in miscarriage. While euploid embryos have the highest success rates, miscarriage is still possible after a euploid embryo transfer. Miscarriage rates after transferring a euploid embryo are estimated to be approximately 10 to 15%, so still much lower than what we see in the general population of patients who conceive on their own, unassisted. That could be anywhere roughly from 20 to 30%, maybe even as high as 40% if patients are older. It is even more rare after a euploid transfer. Once you see a heartbeat, the risk drops to under 5%. So I want to go through the key risk factors or underlying possible reasons. The truth is, you may never know the reason, but a lot of times we think of it as still being something to do with the overall embryo quality, and I'll explain that further, uterine and placental health, and also general health, chronic medical conditions and things like that. So let's first talk about why this could still be the embryo, because that's a major source of confusion. PGT normal does not mean perfect. And while you're ruling out major abnormalities, whole chromosomes that are missing in all the cells of the embryo, remember that what we're able to assess with PGT is very limited. You're looking at a really small subset of the total number of cells that make up the embryo, only like 4 to 5, maybe up to 10 cells of a 200 to 300 cell structure. And when you do the biopsy, some of these embryos could be mosaic and still contain some abnormal cells that aren't picked up by the biopsy. The resolution of the testing is also limited. You can only zoom in so far. So anything that's smaller than 5 million base pairs of DNA that's missing or duplicated is not going to be detected. And if those duplications or deletions happen to interrupt the functioning of key genes, then yes, this could be a cause of miscarriage. This is something that I have picked up occasionally when I've had patients have a euploid embryo that ends up in miscarriage and they do a DNC with microarray testing. That technology can actually pick up those micro deletions and duplications, and sometimes we find them and we think, okay, this is probably the reason why this happened. While PGT testing is primarily screening for aneuploidy, are there extra or missing chromosomes in this embryo, it's not necessarily looking for all the different genetic things that can go wrong, like gene mutations or small structural rearrangements. And this could impair development even if you have all the chromosomes in all the cells of the embryo. PGT doesn't detect errors in gene expression, so even though you might have all your chromosomes, the instructions on how the genes should be turned on or off may be faulty. And while you have some embryos that are genetically normal, that doesn't mean their cells are going to function normally. You can have breakdowns in other ways in cellular function, metabolism, and this can lead to things going wrong with embryo development. Embryo development is highly complex, and having all the chromosomes doesn't guarantee that an embryo is going to properly develop into a fetus. Beyond the embryo, there's also the uterus and the reproductive tract to think about. This can be another major factor. You need a receptive endometrium for successful, sustained implantation. And issues can include things like a thin endometrial lining that can't support the pregnancy, fibroids, polyps, adhesions, scar tissue that can disrupt implantation, even chronic endometritis, inflammation or infection in the lining. Even a perfect embryo is not going to be able to necessarily overcome a suboptimal uterine environment. So the key is going into the transfer, making sure that you've had normal uterine cavity imaging. It's been done recently enough, and you've ruled out major things like a hydrosalpinx in the fallopian tubes. There can also be problems with the crosstalk between the embryo and the lining, and even vascular development in the lining. This can be due to things like scarring or prior surgeries that have just changed the way the tissue behaves in the lining of the uterus. And this can lead to problems with how the placenta forms in early pregnancy loss. Placental development begins between 7 to 10 weeks, and it's critical for sustaining pregnancy. So any errors in the development of the placenta can cause issues like poor blood supply leading to pregnancy loss. And then we have to think about general health and chronic medical issues. So it's really important to rule out things like a blood clotting disorder, for example. Antiphospholipid syndrome is something that I will screen my patients for after a euploid embryo resulting in a pregnancy loss. Even though the guidelines say to do this after recurrent pregnancy loss, which is 2 or more losses, if someone has a euploid embryo that results in a loss, I know that it wasn't due to the chromosomes, and so I always look for things like APLS, because giving baby aspirin while prepping for the transfer and then injectable blood thinners like Lovenox once they're pregnant can actually prevent further miscarriage if it was due to APLS. Giving blood thinners for no reason is not advised, and this is something that I know is given out like candy in my field, but if you have an actual condition like APLS, then it is warranted. Also be issues like uncontrolled thyroid dysfunction, diabetes, insulin resistance, as well as autoimmune flares from disease that isn't well controlled. All of this can be associated with pregnancy loss outside of chromosomal imbalances in the embryo. Elevated BMI is also a factor, especially over 40. This has been shown to be associated with a higher incidence of miscarriage and implantation failure. So that's always something to try to optimize. Maternal health can directly influence the ability of the embryo to implant, placental function, and embryo development. So it's really important to go into every transfer the best version of yourself and try to control your chronic medical conditions as much as you can. The key takeaway from all of this is that while PGT does increase the chance of success, it's not going to completely eliminate your miscarriage risk. It is going to bring it down considerably because at least you know that at a high level, the chromosome content of each embryo is normal. The rate of miscarriage is really low. It's less than 5%, especially if you've already seen a heartbeat. The best thing you can do is try to utilize the best embryo possible with the tools we have to evaluate them and ensure that the reproductive tract looks good and optimize your health as much as you possibly can going forward. Not everything is in our control, and stories like this can be really scary, but I think as long as you have done everything that you can, leave no stone unturned, go into it with your best foot forward, trust the process, and move forward and try.